can start thinking about that. And we'll see if the checklist can help us from having a really bad day, too. Now, I'd like to spend the next little bit telling you a story of the development of the WHO Surgical Safety Checklist. And if you've read Atul's book, The Checklist Manifesto, it actually goes through the story through his eyes. So now you get to see the story through my eyes. And the story is a little bit different, but pretty much the same. It's a story of a problem, and a problem that everybody recognized in the world of healthcare in the United States and around the world, and that is the problem of how to deliver surgical care, needed surgical care, in a safe way around the world. So this whole thing started out for me when Atul Gawande stopped by the other place where I work one day a week now, which is a malpractice carrier across the Charles River in Cambridge. And he asked me if I would help him with a project, and I asked him what the project was, and he said the WHO wants me to do something for them, and they've been after me for a year, and I keep saying no, and they keep coming back. And I asked him what that was, and he told me that it was to improve the quality of surgery globally. And I told him then that I thought that was a great project, and I would love to help, but I had no idea what it was that he wanted me to help him do. That was a giant goal, and the very first thing we tried to figure out was what the problems were as we tried to figure and find a tool that might help with the problems. So what I want you to understand is when all this work started out, there was no checklist envisioned. The whole thing may have ended up that way, but that's not how it started. It started as an effort to improve surgical care everywhere that surgeons care for patients. So we quickly discovered three things about surgical safety. The first was it's generally not recognized to be a public health problem, and I'll show you a slide that says it is. That there was a lack of data on surgery and the outcomes of surgery, both in the developed world, like our own country, and also around the world. And then we saw this thing that was kind of a universal, and I think it's a universal in healthcare, that's pretty well understood by all of us who are trying to improve things, and that is that even though we know what to do, we don't do it consistently. So a lot of times we know there's a problem, we have a pretty good idea about how to make it better, but if you look at how well we really do what it is that we're trying to do, we don't always do as good a job as we would like to. Now when I talk about surgery as a public health issue, when we first started the project, there was not a single thing written in the literature that estimated how many operations were done every year in the world. So we took that on as a task here at the School of Public Health. And I can tell you that this is just an estimate. Even though this number is now widely quoted, it's a guess. But it's probably a pretty good guess. And that guess is somewhere around 250 million operations are done in the world every year. That's a lot. And to put it into perspective, there's more people who have surgery than people who are born in the world every year. And we know that childbirth and maternal child health is a huge public health issue, as it should be. And I think this also says that enough surgery is done in the world that it ought to be pretty high up on the scale of things that we should pay attention to. Well, we sat here in Boston tasked with making surgery better somehow, or at least that's what the WHO had asked Atul to do. And the very first thing we did was go and look around at all of the things that we could find that might make surgery safer. And when we were done, we had listed literally hundreds of things. I still remember the day that the surgical resident I was working with came over with a list that he had put together and showed me this thing, and I'm like, what am I going to do with this? It was just pages and pages of things that had stuff on it like train the surgeon better, make sure they have the instruments they need, can they see when they do the surgery, is there electricity on, do the lights work, is the water clean? And there's this huge list of stuff. And again, I looked at it, I said, I don't know where to start with this, but as you read through it, it became clear that things kind of sorted themselves, and these are the four areas that they pretty clearly divided themselves into. Surgery is all about a wound, pretty much, and infection is a constant threat to us. And there's been a lot of focus on surgical infection, rightfully so. So it was clear a lot of what we were talking about was around the control of infection and contamination during surgical procedures and the consequences of that. Anesthesia and the monitoring of the patient during the surgical procedure clearly was a problem. And it was much less of a problem in the developed world, the United States, all of Europe. Anesthesia is pretty safe. But around the globe, anesthesia is not so safe, to the point that there are places in sub-Saharan Africa where 1 in every 150 patients having a general anesthetic dies as a result of the anesthetic itself. There were a whole bunch of things that centered on the training and the performance of the surgeon, but when we looked more carefully at it, we called it the surgical operator in the very beginning because not everybody doing surgery was a surgeon. But it became very clear that the surgeon wasn't alone, and it was at that point that we changed it from the surgical operator to focusing more on the surgical team, because it takes a team to do surgery. So that was something that we discovered in this little group very early on in the process. So we wanted to focus on the surgical team and how we could improve the surgical team's performance. And then the final thing was the quality assurance or quality monitoring piece, because we recognized that whatever we were going to do, we wanted to be able to tell if we were making a difference or not. If that could be done, we wanted to see if, indeed, we could do it. So this all became the Safe Surgery Saves Lives program, and in the background there is the building of the World Health Organization, which is on the top of a really pretty hill that overlooks the city of Geneva in Switzerland, and it was there that the whole idea of the surgical safety checklist actually was born. Now, there were a handful of things that we decided on as a group at the very beginning that were going to guide the development of whatever it was that was going to be created. It had to be simple. It had to be able to be used everywhere. So we wanted to build the car that could run in sub-Saharan Africa on the autobahns of Europe and the interstates of the United States. Whatever it did, we wanted something to be measurable around it. How it decreased complications, how it changed mortality, how it improved efficiency, how it changed infection rates. We wanted to have measurable outcomes if we could possibly get them. We wanted it to address serious and avoidable complications from surgery, because if we haven't learned anything else in the last 20 years since Lucian Leape's original groundbreaking research, it's that some complications from surgery are avoidable. And then the very last thing is we didn't want anybody to be hurt by the tool that we were going to come up with. So we had a constant eye on that. We wanted to hurt no patients. Well, this is the end result of that long journey. Now, I'm going to show you in a little more detail exactly how we went from an idea to this, but this is the WHO's Surgical Safety Checklist. And that checklist went on to be tested in a pilot study. The pilot study, which you probably most of you have heard about or are familiar with. If you're not, I'll send you at the end the information to find this. It's posted on our website. And I recommend that if you're going to try and ask other people to use it, that you understand this really important piece of evidence is this study. It was an international pilot study. Here you can see all of the pilot sites that we used. scattered about the world, 2 in North America in Toronto and Seattle, 1 in Sub-Saharan Africa in Ifakara, 1 in London in the UK, 1 in the Middle East in Amman, Jordan, 1 in New Delhi in India, 1 in the Philippines, and then finally 1 in Auckland, New Zealand. At each one of these sites, we got a principal investigator to help us put the checklist in place in some of their operating rooms and then see what it did in terms of both changing the way people did their work and changing the outcomes of the patients that they were taking care of. So I'm going to cut right to the chase and share with you the results that we saw. Now, this is the combined results from all of the sites. I could show it to you cut 1,000 different ways. I can also tell you that what we saw in the developed world and the developing world mirror each other. They're slightly different in degree, but the checklist makes a difference in both settings. And here you can see we looked at a lot of surgery, about 8,000 cases in total. And the checklist, you can see at baseline and then with the checklist, and then the significance in terms of a p-value, the checklist made a difference in the mortality of patients, in the incidence of any complication, in the incidence of surgical site infection, and in the incidence of unplanned return or reoperation, taking patients back to the operating room for a problem that needed the operating room to fix. So in this study, under these circumstances, in all these places, the checklist, the WHO checklist, made a difference, and it made a significant difference. That study was published in the New England Journal of Medicine. Now, subsequently, we published this in another article, which are the results of a survey of attitudes about checklist use among the clinicians at the study sites. So here you can see we asked a whole bunch of questions, and while when we ask people if it's easy to use or people think it improves safety or it takes too long to do, you can see that the splits are about 80-20. 80% of people think that the checklist is a good thing and it doesn't take too long and I liked it maybe, but when we ask them if they would want one or not, the split moves from 80-20 to 90-8. And that's been fairly reproducible as we've looked around the world at how people feel about the checklist once they actually start to use the checklist. So I think it's a powerful testament to people to using the checklist by people who have actually used the checklist. So I want to show you real quickly how the checklist was developed, just to give you the idea that it took time to get it from where it started to where it ended up, and it's going to take time to get it from where it starts now to where you want it to end up in your own hospitals. So I call it a trip, and it was quite a trip, and I want you to see how different it looked in the beginning from how it looks now. Excuse me. We took every single checklist that we made, and we saved it. And I'm going to show you some that are spaced out, sometimes by months between versions. In total, there were more than 100 versions of the checklist as it was moving through its development. So here you can see one of the very earliest versions. It's vertical. It has check boxes. Most of the language is very different than it is today. It went from that here, all of a sudden it gets these beautiful pastel colors, and it's still vertical. Now, one of the constants here, you can see from the very beginning, is its 3-part nature that persists to this day with a sign in, a timeout, and a sign out. You can see here, the checklist sometimes grows as we entertained putting more things on it. The language is changing between every version of the checklist. Here, the font shifts, where we go from one kind of type to another kind of type to try and make it more readable. Here you can see something that came and went from the checklist. Some hospitals do this now if they find it useful to them, and that is the signature block. that's on the bottom. In some places, that can be very, very helpful. In other places, it ends up being very counterproductive for the work that we're trying to do. Here you can see the signature block in some controversy disappeared again from the checklist version that went from the last one to this one. Here you can see one of the biggest changes that was made. This actually happened in testing in the Canadian pilot site in Toronto, where the idea of the horizontal, the landscape version of the checklist was first experimented with. We saw the Canadian version, thought that it was a fabulous idea, and that's the way that the checklist is generally displayed by most people today. Here it's 3 checklists on one sheet of paper. Basic underlying anatomy is very clear. The sign-in, time-out, and sign-out portions of the checklist. Here you can see a little bit of an experiment to put a research tool down in the corner there, a thing that a tool calls the surgical APGAR score. And then finally, the first public version of the checklist that was actually released beyond our little experimental community. Again, the pretty pastel colors, the horizontal nature of the checklist, the 3 checklists in one idea, and pay attention now to that information, the sentence in bold type on the bottom, because we're going to talk to you about that, and it is an absolutely critical part of making the checklist work in your hospital, and that is, this checklist is not intended to be comprehensive. Additions and modifications to fix local practice are encouraged. Those are the most, of all the words that are on this checklist, those are the most important ones. Because letting you change it to meet your needs is absolutely critical. Even if the only thing that you do is put your own hospital's name on the checklist, changing it in some way to customize it for your hospital is incredibly important, and we'll talk about that. So this is the most current version of the WHO Surgical Safety Checklist. You can see the logo of the WHO Patient Safety Division up at the top. And again, it's the 3-column, 3 checklist. Some of the words have been changed over time as we've learned things about the checklist in the field. But this is the basic WHO checklist that I'll show you in just a second where it's used around the world. And that's here on this map, which is on the WHO website. We have links to it on our website as well. It shows you graphically all of the hospitals who have downloaded the checklist from the WHO and registered their hospitals. And you can see they're scattered on all the continents that are inhabited. It's in multiple countries, in some countries in relatively high density. But you can see that it's virtually spread everywhere that operations are done. There's more than 4,000 hospitals now that have downloaded it. We have confirmed that about 1,800 of those 4,000 are actually actively using the checklist in at least one operating room when they do surgery every single day. Now, I want to give you 2 more pieces of evidence because as you do this work, I think you'll find that there are particularly physicians and surgeons that evidence means a lot to, as it should, when we're asking people to change practice. And that's evidence from 2 studies that have studied the idea of a surgical checklist, not necessarily the WHO checklist, but a checklist. The first is the SURPASS checklist, which is out of the Netherlands. It's a very extensive instrument. It's difficult to implement. It goes from the admission of the patient through to the discharge. But the important piece is that in the Netherlands, in hospitals very similar to those in South Carolina, they showed significant reductions in death and complications by using a surgical checklist. And then this study from the Veterans Administration, which has a similar kind of effect in combining a checklist with team training and showing a mortality reduction of about 20%. Now finally, I want to remind you about the Institute for Healthcare Improvement, who was our first partner in the United States in spreading this. I know that many of you did work around the time of what the IHI called the sprint. They also worked to modify this checklist and make it more user-friendly for hospitals in the United States. And what you see if you look closely at this checklist is things added to address skip measures in particular. There's a question about hypothermia. There's another question about venous thromboembolism prophylaxis. But this checklist has been available through the IHI for some period of time. Now, when we started the Safe Surgery 2015 South Carolina program, together with the South Carolina Hospital Association, we recognized that the checklist needed to be altered again for the special needs of that program and changed it. I'll show you that template in just a little bit, but I'll also tell you that one of the things that we've learned in the United States is that it's very useful as a teamwork and communication tool, and that was one of the things that we should really emphasize. When you told me about a good day in the operating room, that's what you were telling me about. I need information. The communication needs to be better. I want to feel like the teamwork is good. Well, let me show you that I believe that teamwork can have consequences. This slide, which I call the Site C slide, is from one of the sites in the developed world where their baseline performance was already excellent. And you can see it up at the top, giving antibiotics on time almost every time, adherence to 6 important safety indicators well into the 90s. That is performance that is really hard to obtain. And the interesting piece to me is they put the checklist in place, and those performance measures didn't really change very much. But what does change is the complication rate, the death rate, and the infection rate. And while I can't say for certain what is doing that, my personal belief is that in this hospital, a big piece of that is around communication and teamwork, that the checklist and putting the checklist into place in the hospital brought to their operating rooms. Something made the infection rate drop, something made the complication rate go down, and I believe strongly that it's teamwork that does that. So here's the South Carolina Surgical Safety Checklist template. You can see that it's been altered from the WHO template and that it now has identifiable sections for both briefing, which is all about communication, and debriefing. And that's the major difference between the original WHO checklist, the IHI version, and now the South Carolina version. It's really honing in on the teamwork and communication pieces of the checklist. So when hospitals tell us they routinely do the timeout, what I would tell you is that's not enough. And if you do the surgical safety checklist, the South Carolina version of it, it will take you down a path to improve communication in your operating rooms. This shows you the middle column of that checklist and how little of it is actually based on the universal protocol or the recommendations of the Joint Commission. Just a little teeny piece. Most of it, there's a skip measure there for antibiotic prophylaxis, but most of the rest of it is built around trying to improve communication. This shows you another way of looking at the South Carolina Surgical Safety Checklist that highlights, again, things that the Joint Commission asks us to do, things that the skip measures ask us to do, and then finally, things that come to us from the WHO checklist or from the extra work that's been done on the South Carolina checklist to make it a more powerful